The topic that I chose for my cat was depressive mood disorder. My patient is a 28-year-old Hispanic female that presented to the clinic with a past psychiatric history of anxiety and depression. Today, she reports feeling like she's living the same day over and over again, as well as having hopelessness and helplessness about her current situations. Right now, she's living with several stressors in her life related to family issues, continued conflict with an ex-boyfriend, work, and school. She reports taking Lexapro, hydroxyzine, and trazodone in the past, having stopped the medications due to her mother's disapproval. She would like to try that regimen again. She explicitly denies any suicidal or homicidal ideations or past attempts, and she denies OCD, panic attacks, or any episodes of mania and hypomania. Vital signs show an afebrile patient that's 5'3", 140 pounds, with a blood pressure of 106/70. Her mental status exam was pretty unremarkable. She was alert and oriented ×3. Her general appearance was appropriate grooming, appears stated age, medium stature, average build, casually attired with good eye contact. Her gait and station were normal, with no psychomotor agitation or retardation, and no rigidity, tics, tremors, or APS noticeable. Her speech was a normal rate, tone, and volume. Her thought processes were linear, logical, and goal-directed. Her thought content had no paranoid ideations or no suicidal or homicidal ideations. Her perception was that she denied any auditory or visual hallucinations. Her mood she described as being okay, and her affect was mood congruent and appropriate. Her judgment and insight were both good. Due to her past history of anxiety and depression, we did not do any labs or imaging, but our assessment was major depressive disorder, recurrent moderate, and anxiety disorder unspecified. Our plan for this patient was to restart her on Lexapro 10 milligrams every morning daily for depression, start her on trazodone 50 milligrams every night for 3 days, then 100 milligrams every night onward. Start her on hydroxyzine 25 milligrams every 8 hours as needed for off-label anxiety. We also referred her to support therapy for both her anxiety and depression. So depression is highly prevalent throughout the world, being particularly high in developed countries, with the United States having a lifetime prevalence of 17%. Females have nearly double the prevalence compared to males, and it's likely these rates differ due to etiology of depression varying between the sexes. It's been noted that the prevalence of major depression decreases significantly with increasing age above 65, demonstrating a higher prevalence in a younger adult population below 64. The risk factors linked to major depression can be categorized into 3 large groups. So there's internalizing factors such as genetics, neuroticism, low self-esteem, early onset anxiety, and past history of major depression. Externalizing factors such as substance abuse and conduct disorder, or adversity, which is I think what most people think of: trauma as a child or adult, stressful life events in the past year, parental loss or disconnect, marital problems, history of divorce, lack of social support, and low level of education. As for the pathophysiology behind major depression, depression is a multifactorial in nature. It's highly affected by the above mentioned risk factors, but also proven to have a link to altered brain structure and function. Most notably, depression is shown to cause an abnormal functioning of neurotransmitters, including serotonin, norepinephrine, dopamine, GABA, and glutamate. Anatomically, long-standing and untreated depression has been shown through neuroimaging to cause an increase in ventricular brain ratio, smaller frontal lobe volume, and smaller hippocampal volume. For clinical manifestations and diagnosis of depression, the American Association of Psychiatry most recently came out with their DSM-5, which has the diagnostic criteria for major depressive disorder. So for these patients, it's diagnosed with patients who suffered at least one of the major depressive episodes. An episode is a period lasting at least 2 weeks with 5 or more of the following 9 symptoms. So they either have depressed mood, loss of interest or pleasure in most or all activities, insomnia or hypersomnia, change in appetite or weight, psychomotor retardation or agitation, low energy, poor concentration, thoughts of worthlessness or guilt, and recurrent thoughts about death or suicide. There are some complications that can occur with major depression, including, in addition to those anatomical brain changes that seen with long-standing and untreated major depression. These encompass physical, emotional, psychosocial, and substance abuse-related complications. Physical complications for depression include excessive weight gain or loss, idiopathic pain, and even physical illness. Emotional and psychosocial complications generally include anxiety, panic disorder, social phobia, and agoraphobia, social isolation, suicidal ideation or attempts, and self-mutilation, all of which have the potential to lead to family and relationship conflicts, as well as interfere with motivation and effectiveness at work or school. For considering differential diagnoses, you always have to look and see if there's any other general medical illness that could be considered or ruled out, especially in new onset depression. So in order to do this, you have to have a thorough history, physical exam, and often laboratory tests such as a CBC, TSH, Chem panel, HTG urinalysis. It's helpful in differentiating between depressive mood disorder and depression due to physical illness. Another differential diagnosis could be ADHD, which is similar to depression in regards to their difficulty in concentration and attention, but it's distinguishable in its persistent nature and lack of sleep and appetite disturbances or suicidal ideation. Schizophrenia and bipolar should also be included in your differential diagnoses, as well as adjustment disorder with depressed mood, which are both pretty common due to with the link to psychosocial stressors such as divorce, loss of employment. But these are usually a shorter time period, and they just don't meet the criteria for depressive mood disorder. As for treating depressive mood disorder, it depends on the severity of the depression and the patient's preference on treatment. It's most commonly treated with pharmacological and or supportive cognitive-based therapy, the goal of treatment being to cause symptoms remission as well as return the patient to their baseline functioning. There's a very large variety of medication classes available for treating depression, with the first line of therapy typically being SSRIs due to their trial-proven efficacy and tolerability. Alternative options for initial treatment include SNRIs, atypical antidepressants, and serotonin modulators. Medication classes such as tricyclic antidepressants and monoamine oxidase inhibitors are generally not used for initial treatment due to their adverse effects and increased likelihood of overdose. Comorbid conditions should also be taken into consideration whenever choosing pharmacological therapy, being aware of drug-drug interactions and what effect psychiatric medication will have on the patient's quality of life. The prognosis for a patient with depression is shown that the course of illness for a patient with major depression varies from patient to patient, often involving many periods of recovery and recurrence throughout their lifespan. Studies show the average time it takes for a patient to recover from a major depressive episode is roughly 20 weeks, both with and without pharmacological treatment. The risk for recurrence is shown to be greatest during the first few months of recovery and decreases with time. Depressive mood disorder differs for each patient, and there are many other clinical factors that play into the risk for longer recovery and more frequent recurrence. In conclusion, even with depressive mood disorder being such a prevalent condition in the United States, ranking second among all diseases or injuries and causing disability, it's often missed or overlooked by primary care providers. Studies have shown that depressed patients visiting primary care clinics are only identified and diagnosed with depression 50% of the time. Since the majority of patients with depression are more likely to receive therapy from a primary care provider instead of a psychiatrist, it's vital for medical providers to recognize the signs of depression and to have a baseline knowledge of how to treat it.